Today we are going to discuss an approach to a central nervous system case, especially hemiplegia. So my final year student will be presenting the case. My name is Dr. M.G.K. Pillai.
My name is Angel.
And another student is actually volunteered to sit here for eliciting clinical science. You can introduce yourself.
My name is Padmanabhi.
So let us start.
Yes, sir.
Right.
A 50-year-old Shamna hailing from Aluva is a homemaker. She is a right-handed individual. The presenting complaints are weakness of right upper limb and lower limb since 2 weeks and deviation of angle of mouth towards left since 2 weeks. History of presenting complaints. The patient was asymptomatic 2 weeks back when she developed numbness and weakness of right upper limb while she was washing clothes, following which it resolved after half an hour and was also taken to hospital and given medications. Similar episode was also noted at Saturday night when she was doing household works and had weakness of upper limb and lower limb of right side and was taken to hospital and resolved in about 1 to 2 hours. The current episode developed as numbness of right hand at 9:15 am while she was washing clothes, which was sudden in onset, then gradually progressing to weakness of right leg over 2 hours. It started to be felt in the fingers first and then to upper arm, to the face also. After that, it was also progressing to right leg, starting from thighs to the toes, and had difficulty to stand up from sitting position and walk. She was then brought to Amrita. The patient cannot move her right arm, can't button the shirts, can't comb hair with her right arm. She also complained of angle of mouth deviation to the left. She had difficulty in drinking water as she had cough as she drinks and difficulty in swallowing the food. There was also a slurring of speech. There is no history of loss of smell or double vision or decreased field of vision or difficulty in moving the eyes in a particular direction. There is no numbness in the face or photophobia or difficulty in chewing or opening the mouth. There is no drooling of saliva or difficulty in halting food in mouth. There is no history of hearing abnormality or ear fullness or rotatory movement in eyes. There is no history of difficulty mixing food in the mouth or decrease in the taste sensation. There is no history of vomiting or nausea or headache or fever or head injury in the past. There is no difficulty in movement of the left upper and lower limbs. No bowel and bladder complaints. There is no history of cough, chest pain, or significant loss of weight or loss of appetite. There is no history of palpitations or sweating or giddiness. Past history. 4 years ago, she had a history of deviation of angle of mouth to the left and difficulty in closing the right eye. She underwent physiotherapy for 1 month and recovered completely. History of hypertension during the episodes, otherwise she is normotensive. Diabetes mellitus since 7 years and is on glycomet, and since 3 years it was changed to glimepiride and insulin. There is no history of tuberculosis or tuberculosis contact. Surgical history, non-progressive labor and hence lower section cesarean section was done. Personal history, mixed diet. She is having normal sleep, normal appetite. Bowel and bladder movements were normal. There is no habituations like smoking or alcohol. Menstrual history, menarche at 14 years, menopause is not attained, regular cycles, she is having menorrhagia and also vomiting during the periods. Family history, her mother is diabetic, her uncle is also diabetic, her father died of carcinoma stomach. Drug history, she is on glimepiride and insulin. Allergic history, she is allergic to dust.
So that's a history part. So what is the chief complaint here?
Weakness of the right upper limb and lower limb and also deviation of the angle of mouth towards left.
So right side weakness. So when you get a patient with weakness of the right side, what is in your mind is this is a central nervous system disease affecting the power. So you will think of a disease that affects the motor system, leading to weakness. Then, again, your knowledge in anatomy will help you to think of the lesion is possibly inside the brain because there was involvement of the face as well. Because weakness on one side of the body can be due to a brain disease inside the brain or in the spinal cord. So this patient had weakness of the face that points the lesion is in the brain because facial involvement cannot occur in the spinal cord. So this is a disease that affecting the motor system in the brain. Now, what is the other complaint?
Deviation of angle of mouth towards the left.
So, face is deviated left. What do you understand from that?
That means that is the normal muscles are getting pulled, like the
Yeah,
limbs are
that
getting
means
pulled.
the opposite side is
Weak side.
weak. Okay. That means same side face and limbs. So that picture you can get in certain areas of the brain that you will come to know. So once, what is the onset? Is it sudden or gradual?
After starting, it is.
No, when what she was doing.
She was washing the clothes while she
That's
did.
all. So when she was doing some work, activity. So when there is a disease affecting the blood vessels, it is quite evident it is cerebrovascular accident because the onset sudden. And while working hours, what does it convey? It conveys that it is possibly coming in the either ischemic or hemorrhagic. Both can. It means embolic or hemorrhagic activity. But in these two, which one is possible? Much more chance is for embolic, because is there any headache?
No
No
intense
headache. No, seizure can occur in all these groups, but even then there is no severe headache and not a hypertensive, no history of discontinuing medication like that. So chance is going for, and then what is there anything in the history to think of a source of emboli? Any disease of the heart? It is not there. Any history of arrhythmias which can provoke?
No.
What is her age?
50 years.
50 years. Can atherosclerotic disease of the main vessels produce
Yeah.
plaques inside the main vessel, means aorta, root of the aorta? So it can be a vessel-to-vessel emboli. What you should ask in the history is there any palpitation history? Because a structurally normal heart disease, patient can have a small ischemic focus in the heart, which can precipitate an arrhythmia, especially atrial fibrillation, which is well known to present with embolic disease. This chance is embolic because the patient was working and sudden onset. What is there to support this view? Was there any similar incident?
Yes, sir. Two incidents previously was.
That means there can be another embolic or ischemic event, possibly embolic, which occurred 1 or 2 times prior to. But none of these events were preceded by arrhythmias. That's another thing. And there is no definite chest pain also. Okay. Then is there any, then you should also ask in the history, is there any disease other than the heart cardiac diseases which can lead to this phenomenon, means arrhythmias? Is there a thyroid disease?
No, sir.
No, there is no thyroid disease. So in that case, again your question should be, what are the causes of atrial fibrillation other than this that you think of? It can be valvular heart disease, it can be inflammatory heart disease, myocarditis, it can be ischemic heart disease. So like that you will go one after the other and you will find out. Family history of any heart disease is there. It can be either muscle diseases of the heart, myopathies, cardiomyopathies, then congenital heart disease. So one by one we will ask symptoms which can lead to this entity, arrhythmia. That is how you will expand the history in central nervous system disease. Then finally you will conclude history wise, because the symptom arrhythmias may not be lasting long, because at the onset or within few minutes the patient have an embolic phenomenon. Or some of the heart diseases that may not be manifested because not evaluated. This time it is presenting with a complication. So diseases can present with a complication without its own symptoms. Often we find out a communication between the heart. An embolus can be found on the right side, systemic venous system, can come to the right heart. Then through it can go to the other side because there can be a significant ASD. So the first presentation can be an embolic, systemic embolization. So whatever it is, this is an ischemic stroke, possibly embolic. The onset and the progression helped us. Unlikely to be hemorrhagic because the other features associated with the hemorrhagic stroke is not there because no neuronal irritation was there. Constant, again, seizure, headache, then signs of raised acidity, all these should be there or not. So likely diagnosis will come to. Then what is the next part? No, history only.
Past
No,
history.
what happened with that? Means temporal course of the illness.
Oh, yes.
What is the course of an embolic stroke? After some time, what can happen?
It reduces in
Naturally. Whereas what is the course of a thrombotic stroke?
progressive.
That's how. A patient with a thrombotic usually presents in the morning, gets up with some weakness or maybe falling down because of that weakness, then goes to bathroom or does something, and after 1 hour or so, the patient is worsening. Because they were waiting for this to go back, or they are not bothered because it has minimal weakness. But what will happen in the thrombotic stroke is it will gradually increase because the elements will increase at the site of the injury. More and more platelet will aggregate, and more fibrin and deposition, everything will happen. Clot formation becomes complete. So it is evolution. It is evolution. Stroke in evolution. So all this will be evident in that. That's how you will conclude as thrombotic stroke. If there is no evolution, full clot, then it cannot stay its own way. It may break and dislodge to a distal vessel. So improvement is high chance in embolic, whereas worsening is the usual course in thrombotic. Signs of neuronal irritation are usually there in hemorrhage. That is how you will conclude the occurrence of a stroke and a possibility. Then you will think of the reason for this. Whether it is a precipitating illness or is a source of embolic. Okay. All these will ask questions. So whenever you say no history of palpitation, the meaning is there is no arrhythmia to precipitate this embolic stroke. When you say there is no childhood history of joint pain, then you say there is no childhood history of joint pain. You are searching for a rheumatic heart disease with possible stenotic lesions, which is commonly seen that. Okay. So then what is the next important thing? First attempt is this. Is it a nervous system disease? Then is it cerebrovascular? Then you will also think of other disorders that can mimic cerebrovascular accident. Is it a lesion suppressing or compressing the vessel from outside? A tumor. So you will have symptoms of raised ICT or space occupying lesion. Symptoms will be there. Okay. Then if it is a vasculitis syndrome, patient will have other features of autoimmune disease and also features of vasculitis. Means constitutional symptoms will be there. Non-specific symptoms can be there. Other rheumatological symptoms will be there. That's another part of the history. Okay. So part by part you will think of other etiologies that can affect the vessel. First you will think of that vessel with anatomy. That is how, what is I told you in neurology, the first question is where is the lesion, and second question is what is the lesion. Okay. So history wise and the past history also, no other similar illness and rheumatic fever also not there.
She actually had 4 years back a history of deviation of angle of mouth to the left and difficulty in closing.
Is there any more description in that?
No, sir. Like she underwent physiotherapy and resolved.
Now, if it is a sudden onset with any other symptom, it can be a TIA. But the thing is, the seventh granular lesion can also be due to element type is Bell's. So you should ask questions and make sure that this is not Bell's, but this is possibly that only. Okay. So now you cannot deny because the rest of the history to support or to deny is not available. Patient is just telling there was disease affecting that and no other symptoms other than the facial involvement. You will put a question mark and keep it there in the history. Okay. So the risk factor here in this patient is mainly
she's diabetic.
Hypertension not there.
Diabetic.
Dyslipidemia.
She just had hypertension during the episodes. Otherwise, she is
That
normal.
episode, because whenever there is an ischemic stroke, a reactive hypertension is well known. That is why we will never try to reduce the blood pressure when there is an ischemic stroke, because it is the reaction of the body to overcome that block, either through the lesion or by facilitating a collateral circulation. But once you reduce the blood pressure, what will happen? You are blocking the
Supply to the
effort of the body to save the penumbra. So a core infarct will be there and a penumbra surrounding. Penumbra you can save. That is all the effort that you are putting is to save the penumbra. Okay. Yes.
Examination. General examination. The patient is conscious, cooperative, well oriented to time, place, and person. She is well built and nourished. Height is 162 centimeters. Weight is 88 kilogram. BMI is 33.58. She is obese. Pulse 66 per minute. Normal rate, rhythm, character, volume, condition of vessel wall. No radioradial or radiofemoral delay. All peripheral pulses were palpable. BP 140/90 mmHg. Left upper arm in supine position. Respiratory rate 16 per minute. Temperature 98 degree Fahrenheit. There is no pallor, no icterus, no clubbing, no cyanosis, no generalized lymphadenopathy or edema. Head to foot examination. There is no neurocutaneous marker seen. The cannula is on the left forearm without any thrombophlebitis, and LSU scar is present. Examination of the nervous system. Higher mental functions. The patient is conscious, oriented to time, place, and person. Memory, immediate memory, recent memory, and remote memory is present and intact. Intelligence is normal. There is no hallucinations or delusions. Speech is spontaneous. Repetition, naming, and reading is present. Writing is not assessed. Cranial nerve examination. Olfactory nerve normal.
Can I interrupt there?
Yes,
what you told, speech is important. Yes, so speech is very important in the evaluation of a cerebrovascular accident. What way it is helpful for a beginner?
We can detect the area, like which area is involved. If it is a motor area or the
A better localization in the form of what? Cortical or subcortical? Because hemiplegia with the facial movement can be there in the internal capsule. Means above the level of the nucleus it can happen. Southern nucleus, the response. So whether it is cortical or subcortical. If it is in the cortical, one of the important cortical function is speech. That's the most important thing. So not only the area but also the function, means superficial part of the brain. Then what about other things that will support a cortical hemiplegia than subcortical? Any other thing you can take from the history?
cortical sensations,
Other cortical functions.
consciousness, emotions.
Consciousness depends, because it can be even in brainstem. Ascending reticular active system is mainly there. So it will help you, but it is not the only reason. Then what about apraxia? It is a cortical function. Speech. Then what about any other thing? What is cortical blindness? Means special sensory type. If the patient has got visual disturbances of cortical type, it is helpful. So localization to cortical hemiplegia depends upon. Then history of seizure, more of cortical. So some important points in the history. Most important is speech. Again, area wise, if you think it can, you can think of a motor speech or a sensory
speech.
And also you can assess the conduction. Is there any involvement of that loop that connects between the speech areas? Or repetition, for example, it will be affected. So we'll go into details of that when you discuss speech in detail. This is mainly an approach. But if there is speech involvement, that helps us to say there is cortical. That means the language function. If you ask something, the patient is able to hear it, no hearing disturbance, the analysis is that comprehension and the output of the speech. Okay, that means a language is something which the patient understands, the speech is something which is coming out, verbal component. Okay, then also you will think of, she had slurring. That means a peripheral disturbance of the output, that is speech. That is actually dysarthria, son, which you will consider as is from the lips or from the inside oral or from the throat, means larynx. Okay. And also you should think of a coordination dysfunction as in the case of cerebellar disease. So if it is only a dysarthria, all these you will consider. But if it is inability to comprehend, means patient is not understanding what you are telling, it is a central language dysfunction. Then if you ask something and he says something, there is no comprehension. So it is a real language problem. So if the patient is not able to understand, it is a sensory speech. But if his output is only minimal without grammar, it is a motor speech disorder. And if no output from a speech, it is global dysfunction combined. This is what you should understand in the beginning. Then if you go to the details of each component, you can have a lot of discussions. Okay, this is the beginning of the approach, speech. That is another way. It is high volume, meaningless speech is sensory. Low volume, agrammatical is motor.
Cranial nerve examination, olfactory nerve, the right and the left is normal. Optic nerve.
So when you say that cranial, you have to say able to smell common objects. Yeah, without seeing it. Then you can say which common object, coffee powder or soap, something. So separately.
Optic nerve, visual acuity was tested, and in the right it was 6/9 and in the left it was 6/9. Visual field, the confrontation was done and it was normal. Color,
so the confrontation test, 1 meter apart, you know that, yes, okay. Examination also will come to details later.
Color vision, Ishihara's chart was used and it was normal. Fundus could not be checked. Oculomotor, trochlear and abducens nerve, there is no diplopia, there is no squint. Nystagmus was not there. Ptosis was not there. The pupils were normal. Direct and indirect light reflexes were normal, and it was present. Eye movements were also normal.
So pupil examination?
Direct and indirect.
Okay. Can you just let us demonstrate that how to examine the pupil? Because method is important. So when you discuss the direct and indirect pupillary reflex, which part of the brain is involved? It is the midbrain. Again, there is another more details with there. But when you examine the patient bedside, you will first come to that part only. Which part of the brain? Midbrain nerve examination. So you should have a localization, first broad, then very specific. So let us examine that pupillary light reflex, because very often this we will ask the student. Can you? So whenever we ask you to examine the patient, you should come to the right side of the patient first. Yes. Then you have to introduce yourself and you have to get details from the patient, and then you should tell the details that you are going to do. Okay, that is how a system starts. Then you will do, and then finally you have to say thank you. That is the method. You can start.
My name is Angel. So
okay, fine. That's fine. You start. So you are going to elicit the pupillary reflex. So there should be an underlying light with which you will be able to see both the pupils. Then you will expose him to more powerful light, but not very powerful. Ideally, that yellow light is better than this modern thing. Okay. Right. You can put hand like this and then bring. Yeah, that should be the. Okay. So, are you able to see that the first same side, then opposite side? Yes. That means the pathway in the midbrain is functioning properly and it is connected to both eyes. That's all. Okay. So which nucleus in the midbrain?
Edigovespal nucleus.
Yeah. Then it comes through the
opposite.
To both, because it connects both sides. Right.
For the examination of trigeminal nerve, the motor functions were normal on both the sides. The sensory functions were also normal on both the sides.
The extent of the sensory is from the vertex. Top, and just a border left for the cervical nerve, not there. So this border is usually by the cervical nerve. Above that only the mandibular division comes. Okay.
The corneal and conjunctival reflexes were normal on both the sides. Jaw jerk was also present. Facial nerve.
Jaw jerk will be absent normally. You will get only in pseudobulbar palsy or similar situation where both perineal tracts will be affected. So whenever in a patient jaw jerk is present, that indicates bilateral pyramidal involvement. Okay? Right.
Very good.
So no problem. Not.
Facial nerve. Wrinkling of forehead was present. Lagophthalmos was not there. Puffing of the cheeks was present on both the sides. Nasolabial folds was absent in the right side, but it was present in the left side. Angle of mouth was deviated to the left. The taste in the anterior one-third of the tongue was present in both the sides. Drooling of the saliva was absent. The patient was able to evert the lower lip.
And normally you test the taste sensation ideally within a liquid media and non-irritant substances. Okay, there are certain methods are there. Anyway, when you present, this is only a model how to do the examination. In detail, each has to be discussed separately. Right, not now.
For the examination of vestibulocochlear nerve, Rene's was positive both the sides. Weber's was not lateralized. Airborne conduction study was normal on both the sides. Absolute bone conduction test was normal.
ABC, okay.
Glossopharyngeal and vagus nerve. Drooling of the saliva was absent in both the sides. Gag reflex was present.
Drooling of the saliva indicates facial muscle weakness.
Oh, okay.
You mean drooling?
Drooling.
That is when facial muscles are weaker. 9 and 10 usually we will examine by looking at the palate. Position of the soft palate and uvula.
Yes.
Next you are say any collection of secretion in the throat. So if there is significant collection of secretion in the throat, that indicates throat muscles are weak. Because the pharynx and even the larynx is mainly supplied by 9 and 10. So this is the collection that leads to aspiration because swallowing is affected. Pharyngeal part of the swallowing is affected in 9 and cranial nerve. There are 3 phases. Oral part is mainly by cranial nerves 5, 7, 12. 5 muscles of mastication, that is important, pterygoids, very important. 7th, vaccinator, very important, keeping that. 12th is the one that is making the bolus.
Tongue.
So these 3 are very important in the oral phase of swallowing. Second phase is pharyngeal, 9 and 10th mainly. There are many other muscles supported by many other, that is true, but you have to tell you. And another third phase is esophageal. So the second phase will be affected by 9 and 10th. So we'll ask about nasal regurgitation because protection nasopharynx is lost. Nasal regurgitation and aspiration. Also dysphagia, dysphonia, similar symptoms. Okay.
Dysphagia was not present. Secretions were also not present. Nasal twang or regurgitation was absent. Uvula was central in position. Spinal accessory nerve examination. The functions of the sternocleidomastoids were present. Trapezius function was also present.
That has 2 muscles. Okay.
Hypoglossal nerve examination. The position of tongue was normal. There was no wasting of the tongue muscles. Deviation of tongue was absent. Power of tongue muscles were normal. The tone of the muscles were normal. There is no fasciculations.
Also you can say surface of the tongue because when there is a element lesion wasting, the tongue surface will not be smooth. You can see gutters like that. Right? And fasciculations you can see in the resting tongue when it is inside. Tremor we can more easily see when the patient protrudes the tongue. Okay.
Motor system examination. Bulk. Mid-arm examined 10 centimeters from the shoulder. Right side it was 30 centimeters.
That is good. From a bony point, either from bony point you will measure and mark. Okay. So any wasting in anywhere?
Yes sir, just mild in the
mild weakness.
Mid-arm circumference. It was 30 centimeters in the right and 31 in the left. Rest everything is normal.
No.
The mid-forearm, mid-thigh and mid-leg. Tone. Upper limb, there was hypotonia in the right side, normal in the left side. Lower limb, there was hypotonia in the right side.
Is there, and what is the normal, means what do you expect in pyramidal lesion tone?
Pyramidal lesions
Pyramidal lesion,
normally
there will be an increase in the tone in the form of spasticity. Whereas in extrapyramidal lesions, it is rigidity. So, spasticity, there is a phasic difference in the tone and it is velocity dependent. That is the most important point. Okay.
Power. Shoulder, the flexion, there was no power in the flexion for the shoulder, that is in the right side. In the left side,
it's always better to say grading.
Grade 0.
0, 1, 2, 3, 4, 5.
In the shoulder, grade 0 for flexion, extension, adduction and abduction. In the left side, grade was 5. Power was 5 grade. Elbow, flexion and extension, it was 0 for the right side and 5 for the left side. Wrist, extension, flexion and hand grip was 0 in the right side. Left side it was 5. In the hip, flexion, extension, adduction and abduction, it was 0. Left side it was 5. Knee, flexion and extension, it was 2 in the right side. Left side it was 5. For the ankle, dorsiflexion, plantar flexion, it was 3 in the right side and 5 in the left side. For the foot, inversion and eversion, it was 3 in the right side and 5 in the left side.
So this difference in power and tone that happens in nervous system, especially following an injury like cerebrovascular accident, is because of the neuronal shock. So in that neuronal shock, instead of paresis, there can be complete paralysis. Instead of that hypertonia, so increase in the tone in the form of spasticity, there can be hypotonia. So that is an explanation given. But subsequently, this will come back to the classical pattern.
Reflexes, deep
tendon reflexes.
Jaw jerk was absent.
So again, you will describe it as absent, present, brisk, very brisk, clonus. 0, 1, 2, 3, 4. That is the way we will express deep tendon reflexes.
Biceps in the right side, it was 3 plus. Left side, it was 1 plus. Triceps, it was 3 plus in the right side.
So the reflexes are returning early now. Yes, might have been less previously.
And in the left side, it is 1. Supinator, it is exaggerated in the right side, present in the left side. Knee jerk, ankle jerk, brisk and just present in the left side. Superficial reflexes, abdominal reflex, absent in the right side, present in the left side.
That is an important point. Abdominal reflexes will be absent in pyramidal lesions. Means superficial reflexes will be absent. In the case of plantar, it is different. It will be a different opposite pattern. Instead of a flexion, there is an extensor response. But other superficial reflexes will be absent.
Yes, sir. Plantar, extensor plantar in the right side, normal in the left side. There is no involuntary movements present, no pyramidal reflexes seen. Sensory system, for the touch, fine touch and crude touch, normal in both the sides. Pain, superficial and deep pain, normal in both the sides. Temperature, for hot and cold, it's normal for both the sides. Position sense is normal. Vibration sense, it's decreased in the right side and it's normal in the left side. Stereognosis is present. Graphesthesia, normal. 2-point discrimination.
These things depends upon which case it is important. Okay, you can check it, but you should be able to say why you are tested and what is the result.
Yes, sir.
Okay. Whether you are able to identify objects, shape, weight, everything depends. But the situation where it should be tested is also varying.
Yes, sir. Also tactile localization was normal. Cerebellar signs, nystagmus was absent, scanning speech was absent, hypotonia in the left upper and lower limb, dysmetria present in the left and right couldn't be assessed, no intentional tremors, gait couldn't assess. Dysdiadochokinesia couldn't be assessed in the right side, but left side it was present. Heel shin test couldn't be assessed in the right side, left side it was present, and straight line test couldn't be assessed.
So in the cerebellar, you have to separately test upper limb and lower limb and also truncal. Yes. Ataxia is the main thing that you will look when the patient is standing or sitting, means truncal. The other thing is coordination of movements. Coordination of movements with a rapid alternating testing that you are describing it as diadochokinesis. That you will test, again you will see the mistakes. Instead of the rapid alternating, he will do like this. So irregular it will be there. And again, finger nose test, finger test. All this you will do in the upper part. And again, he will be utilizing his heel and placing in the upper part of the shin and then down without derailment, means mistakes. When there is cerebellar disease, he won't be able to move the heel through the shin. That is what we are detecting. Again, when he is walking, if he is walking like broad steps, there is no need to go further thing because he is about to fall. If it is not there, you will make him to walk in a straight line. If it is not there, you will ask him to tandem walking. So we will make the test more specific to bring out the difficulty. If the first thing, normal walk itself is cerebellar, means he won't be able to do the next of the thing. That is not required. Okay. If at all you want to demonstrate, you should be very careful about a fall. Okay. And another test for equilibrium that is mainly for posterior column is the Romberg's. So,
signs of meningeal irritation. There is no neck stiffness or headache or Koenig's or Brudzinski's sign. Skull and spine, no gibbous deformity. Vessels, no carotid bruit could be heard. Respiratory system, normal vesicular breath sounds. There is no wheeze or Krebs. Cardiovascular system, S1 and S2 heard. There are no murmurs heard.
Next important system that I should tell is cardiovascular system first, because cardiovascular system is the reason for most of the embolic strokes. This case also is mainly embolic, suspecting. So next system of importance is cardiovascular.
Cardiovascular system. Okay.
Any murmurs?
No murmurs.
No murmurs. No obvious or evident cardiovascular valvular heart disease. Right.
GA examination, soft, non-tender abdomen. There is no abdominal distension. Summary.
Further musculoskeletal system and nothing.
Normal, sir.
Because musculoskeletal system is important because many of the diseases of the muscular system can affect the aorta.
Okay. Yes.
Okay, aortic diseases, which can later lead to this complication. That's also to be mentioned. That's all. Right. So now we'll come back to summary and then diagnosis.
Summary. 50-year-old Shamna, hailing from Aluva, a homemaker with a past history of stroke 4 years back, right-sided yom and facial palsy, resolved completely after 1 month of physiotherapy, now presented with weakness of right upper limb and lower limb and deviation of the angle of mouth towards left since 2 weeks. The initial 2 episodes lasted for only 1 to 2 hours, but the third episode was progressing, that is initially weakness of the upper limb followed by the lower limb. Right side was so weak that she couldn't lift her hands and legs. She had a history of diabetes mellitus since 7 years and was on glimepiride and insulin. On examination, her BMI was raised. On cranial nerve examination, there was absence of nasolabial fold in the right side and angle of mouth was deviated to the left and flat platysma. On motor system examination, 0 power was noted in the right upper limb and 3 in the right ankle and foot and 2 in the right knee. Hypotonia was present in both right upper limb and lower limb. Reflexes were exaggerated in the right upper limb and lower limb. Brisk in the right lower limb. Abdominal reflex was absent in the right side. Extensor plantar was noted, that is Babinski positive in the right foot. All sensations were intact. Cerebellar signs were absent except hypotonia in the right upper limb and lower limb. Other systems were within normal limits.
So can you elicit 2 physical signs now?
Yes, sir.
Yes, sir. One is how will you elicit a knee jerk. So before you elicit, you have to tell the patient in self-introduction and details what you are going to do. Then when you elicit knee jerk, actually you have to expose the muscle that is involved in that jerk.
Yes,
and also you have to examine the area to rule out any painful situation there.
Yes, sir.
Okay. So after that you will do it and always try to stand on the right side of the patient and you have to palpate the tension. Okay. And then only you should elicit it. Huh? Can you do that? But the muscle should not be pressing over this. ಸ್ವಲ್ಪ ಮುಂಬಿಡ್ರಿ.
Relax your leg.
No, let me see that. Because over the pants only you are doing that. Now try. Don't worry. Because mainly the movement should be from the
Wrist.
wrist. So we'll palpate the tendon and then you'll show like this. This is actually it's pressing. So relax it. Okay. So it's starting.
Oh.
That's all. So free movement. It should be exactly over the tendon. Many a times it is because of the positioning of the patient. And again the patient will be concentrating in that. Then you have to divert his attention with some other activities. It can be holding the or clenching, whatever it is. Okay. So next is how to elicit a plantar response. Already self-introduction, situation, everything is well known to the patient. There's no one to greet or explain the patient. Already I told. And when many people will use materials which are very sharp. You cannot use sharp objects. So ideally a blunt. This is too blunt. So it will be a key only. Key. This is a key. So you will just keep like this. See, laterally rotated. Okay, and the lateral side means not above. This junction is there. Lateral most side. And the reflex means you are eliciting a nociceptive one. Pain and pressure should be there. It should not be stroking. Pain and pressure. So that's all. This is. See, within the first centimeter itself, the response came. That's all.
Yes, sir.
Okay. I'm going to the other side. Okay. And side on the other side. That's all. Okay. So if there is an extensor response, the big toe will come like this and the lateral toes will fan out.
Yes, sir.
And again you can have movements as dorsiflexion and knee flexion. And sometimes this muscle, which one?
Tensor facial.
Tensor facial latae contraction also you can see or you can feel. That is how this reflects. This indicates a pyramidal tract lesion. Okay, many a times we say UMN, upper motor neuron disease. Parkinsonism also is upper motor neuron disease. But there you will not get it. So ideally the pyramidal system should be involved. That is, then only you will get upgoing plantar response, otherwise called Babinski.
Yes.
Then this lower limb, many times this tone, especially lower limb tone testings, or power testings, confusion, because very difficult to test the tone of the lower limb bone. So two tests are frequently done. One is rotation of the hip. You can assess the movement here, rotation. Lateral and medial rotation. Very often you will get good findings, especially in pyramidal lesions. Second one will be the knee, scissor. So if you position the patient properly, you will be able to do it. But if the position is not right, this patient is lying on bed too low, it is very difficult for him. So hold him away from that muscle that is testing. Support just above the joint. That is all. Okay. It is velocity dependent, I told you. Because we are testing spasticity. That's all. In Parkinson's, you cannot do this because it is rigid. Okay.
Yes, sir.
Then, if you want to test the extensors of the lower limb, you have to keep your hand underneath his heel and ask him to press. Press down. See, this is his extensors are. Okay. And again, if the patient is okay standing on, he can extend like this, backward movement. Okay. If he is in the prone position, he can extend up. This movement can be done when he is lying down. That is extensors are tested. Then he can move, he can abduct, he can adduct. Then flexion of the hip. Rotation already discussed.
Yes.
Okay. So upper limb also there is a lot of confusion because one thing that is always confusing is movements of the shoulder. What is flexion, what is extension? Once you are sure about that movements, there is no confusion at all. Okay. So it is very well given what are the movements, because shoulder is the joint with the maximum movement, just like the leg joint, because it is ball and socket. So keep it in that position and you identify the movement, then you test it. That's all.
Yes,
okay. Now we will come to the final part. How to write a diagnosis in a central nervous system case. So here your case was cerebrovascular accident. So what is the first point you will write is? Cerebrovascular accident. Then once you say cerebrovascular accident, you should have the reason for the cerebrovascular accident? Is it a thrombosis or embolic? Whatever you have got from the history and examination. So it is an embolic stroke. That has resulted in what?
Right hemiplegia and right
That has resulted in an anatomical problem, that is
hemiplegia.
hemiplegia. Okay, so anatomy of the lesion is in the vascular artery, where it is, that should be mentioned in the cerebrovascular accident, ischemic or thrombotic hemorrhagic stroke in
Probably left internal capsule.
Yeah, that is in the middle cerebral artery territory. Where it is, if that is cortical or encapsulation. That resulted in
Right hemiplegia and
hemiplegia with the human
facial palsy.
Okay, then
With the patient improving on treatment, and the patient is also
then what is the functional status of the what the patient can do? What functional status is? able to move with support only. Okay, it requires help and support from bystanders.
Yes.
That is his functional status. Yes. That's very important. More information you can write down there, but functional status should be a heading in that. Okay. Yes. Then if you have got additional embolic reason and a valvular heart disease, that also should be one.
Yes.
Because it is the reason for stroke. So mitral valve disease, whatever it is, that should be mentioned if it is there. Yes. Then comorbidities like diabetes, hypertension, that also should be dyslipidemia, all this should be mentioned there. Yes. You can mention obesity, which can lead to diabetes. Can also invite hypertension. Okay, all this you will mention there. Then always the one question is, how will you differentiate between hemisphere stroke and brainstem stroke? There, in brainstem stroke, you will see LMN cranial involvement, number one. More than one tract involvement can occur. Means not only sensory, not only motor, more than one side, means both sides it can occur. It is only in brainstem stroke. Sensory, motor or together, either one side or both sides. So more than one tracts, more than one cranial, especially it will be LMN. Then eye coordination will be affected. That means MLF involvement is seen in brainstem stroke. That is, conjugate movements of the eyes can be affected. So when the right eye moves, left eye accompanies. That will become, that you call it as ophthalmoplegia. So internuclear ophthalmoplegia is classically seen in brainstem stroke. Then vertigo with ataxia is a very important symptom pointing to brainstem stroke. And many patients can have hiccup as a symptom. These are the important points with which you can say it is a brainstem stroke. Most important is LMN. For example, Weber's, third cranial involvement plus opposite hemiplegia. Okay. In many cases, you have seen lateral medullary syndrome. They are actually, motor is not there because it is in the medial part. So lateral part. So 9th cranial involvement plus spinothalamic involvement. Then again you will get a dorsal column. So, and cerebellar. Then sympathetic. So all this will help us to locate that side. So not only the tract, but the cranial nerve. Together will pinpoint the site of the lesion. So associations always helps. Similarly, our case, it is the human facial nerve, then absence of cortical signs, then dense hemiplegia. All supported us to think of a internal capsular lesion. If it is a cortical, more of upper limb involvement or lower limb one can occur. Medial side, more of lower limb. Lateral side, more of upper limb. So, pattern depends on the site and the type of lesion. That's all. Yes. Okay. So, the management steps only you can tell now, because details we'll discuss later. What are the steps of management of this patient? First investigation to rule out
hemorrhagic stroke.
So, we'll send a CT followed by MRI. Then
thrombolysis.
Yeah, thrombolysis is main way. Usually we'll use
Altiplase.
Altiplase in use. Yes. Then follow up with the
statins.
antiplatelets and statins follow up. Yes. That is very important. Hypertension control, diabetic control is required with properly medications, but we will never bring down the systolic hypertension in ischemic stroke suddenly. That is because it can worsen. So slight reduction, 25% or so, if required, monitoring the neurological status. Any worsening we will stop, because any hurry in bringing down the blood pressure can worsen the infarct size. It can extend the stroke. Okay. So thank you for all during this presentation, and
Thank you,
also
sir.
thank you for the UG presentation. You're doing well.
Thank you,
Okay.
sir. Thank you,
Nice presentation, but still you can collect more information and expand it and explain more. Next
Thank you.
presentation you will do better.
Yes, sir. Thank you,
Thank
sir.
you.